Hi, everyone. I'm Danielle Loeb. I'm the lead for transgender care here at in outpatient for general internal medicine here at University of Colorado. And my intention today is just to, we've done a lot of talks on various aspects of care for transgender and gender nonconforming folks. And I wanted to make sure there was some reference for just cross cover for providers that aren't necessarily providing gender affirming care themselves. We all really at this point will be performing offering gender affirming care, because patients are in our clinics. We're going to be cross-covering. There are patients. And so I want to make sure everyone has a certain level of competency with that. And a couple of clinics have had a version of this, like Cherry Creek, and I think it was helpful. So I'm going to try to keep this short. It's only half an hour. So we'll see how that goes. So no financial conflicts of interest, and the medications, just note the medications we use basically in gender affirming care are used off-label. So what is this? What are we going to do right now? A bit of a tour of the resources available. Like, I get questions that often are provided in some. We have some really amazing resources that we've built out here in combination with the Transgender Clinic and endocrinologists there, and also in combination with Laura Mackey and the folks doing the pathways. So I really, really, really want to make sure you know where to find these. That's probably my biggest thing. And then we'll look a little bit at the provision of gender affirming hormone therapy through that lens of the primary care pathway. And then if we have time, we'll take a look at some of the why of the cross cover, of what we do in cross cover. So one site for resources is this website. So it's the CU School of Medicine Gender Diversity Program website. It lives in the CU School of Medicine world. It's on the pages on their websites, so not necessarily UC Health, but we have links to it from within Epic. So from this website, you click to clinical, and there are clinician resources there. The other way to get there is that in Epic, under the UC Health Metro Denver resources, if you click on that, you'll get there too. And so what will you find when you get there? So one thing is there's didactics. There's a talk on providing gender affirming hormone therapy there. It's available to you. And then also above it, which you can't see, is a talk on cultural competency, useful to new staff when they are onboarded in clinics and that kind of thing. And then pertinent to this talk, so there's a whole list of clinician resources that were made for you. These were made for GIM primary care docs providing this care, okay? And in particular, there is a PDF on task coverage. And so you can, if that's kind of all you're doing in this round, I'd recommend maybe printing that out and having it handy for you. There's a lot of other resources that are good to know about, like this epic dot phrase template that gives HPI, plan, letter templates for surgeries, that kind of thing. If you're providing gender affirming hormone therapy, it has these consents, which are really information pages, and also these guides for hormone therapy. So that's one set of resources. This is the task coverage page. So it just covers the major things, like what is the goal testosterone level, and what do you do if it's above range, et cetera. So it just tries to address the biggest issues that may come up for you in cross coverage. Then what has happened since we built all those PDFs is Dr. Rothman from endocrinology and myself and Laura Mackey, and then a team of other folks, including pharmacists, built out these primary care pathways. I could not encourage you more to use them. So there's one for feminizing and one for masculinizing care. The nurses have access to this, and they're well built, and your orders are often built into them. So they're very useful to use. So I'm going to talk a little bit about the provision of trans care through like how we built the pathway, and to show you, it does give you a sort of algorithmic approach by in the pathway itself. So say you're a provider that actually is providing, starting new patients on, you heard the lecture on didactics, or you feel comfortable with your background knowledge. It goes through your steps that you might need to provide. And like these blue things, like if you click on gender dysphoria, it gives the diagnostic criteria for diagnosing gender dysphoria. And like the information sheet, those are those consent forms, they're here. So you don't actually have to go to that other website for anything once you're in the pathway. You can get it all within the pathway, there are links. And it goes, so there's some very brief education, like steps that you need to take to start. But if you're just doing cross cover, I'll look at why this also may be what you use. So it goes through the labs you would use before starting hormone therapy. And then if you look over here, some of the hardest things to do are finding like, what are the right syringes? What are the right needles? Et cetera. So some of the more challenging orders, the referral to speech therapy requires some very specific things. We put in the pathway. So these may come up when you're doing cross cover. I need syringes, I need needles. This is a place, this is where I would encourage you to find it. And then some of these are more like, these are referrals to all the services in gender-affirming care and how to order it. So we just put in the speech because it's complicated. So, and then it takes you down, the next step is, oh, we just did this. I'm going to skip this right this second, actually. Sorry. So the next step it takes you to in the pathway is how to monitor therapy. So this is highly likely to come up when you're doing cross cover. So in this window, it gives you what labs you're usually checking. It gives you the goal of estradiol, gives you the goal testosterone for patients on feminizing therapy. I think I noticed that it does not actually tell you when to check it. If patients are on IM dosing, they should check between doses, just so you know, and we'll add that in. But these are the general, it gives you the goals, and then it gives you, so at the first 3-month check-in, you're going to get more thorough labs, and we'll touch a little bit on why we're getting a lipid at this point. And then at follow-up checks, you're really doing the estrogen, testosterone, and BMPs for the most part, unless you've found something in the lipids. So that's the pathway. And then I just wanted to touch a little bit on the meds we're giving and what they do to people, very, very, very briefly. And this is given much more in depth in the talk, the didactics that I just pointed out on that other website. So what does estrogen do to patients? I mean, I think it's still a good idea to have a feel for this, even if, again, you're not providing hormone therapies, because people ask questions. Like people will say, my breasts are hurting and it's just starting. Why is that? And you're like, oh, well, they're in their first 6 months of hormone therapy. They're starting to have breast growth. That's probably why, so you'll get some questions around some of the changes sometimes. So just to be clear on what does change and what doesn't change with estrogen, you hopefully get improvement in some of the psychological factors associated with gender dysphoria, basically improvement in the dysphoria, increase in breast tissue, you get some skin changes pretty quick. And usually you get, you can get sterility, and that is a permanent change. You can get decrease in erections, changes in body composition. Those are not so permanent. And hair changes are not very dramatic. Patients get a decrease in facial hair, body hair, maybe a decrease in male pattern baldness, but often they're still going to have electrolysis or something if they want to get rid of facial hair. Voice, there are no changes, so that is important. They have to do either behavioral, like speech therapy, or sometimes surgical interventions to change voice. And then estrogen maybe decreases blood pressure, maybe decreases hemoglobin, hematocrit, and then likely does increase LDL, maybe triglycerides. So that's why we're following lipids, at least in the first check afterwards. And then I'm not going to go into all the specific hormone changes, but just to give you a feel of what changes when patients sometimes will call with these questions. What are we giving? So you're a little bit familiar. We're not giving ethinyl estradiol, so that, like the estrogen that's in birth control, hopefully nobody's giving anybody that, because that was what led to all the really bad outcomes in terms of blood clots and things at the high doses you would need for gender-affirming hormone therapy. Oral estradiol, these doses are not real life. Usually people will go up to 8 and sometimes 10. Transdermal estradiol, you could go up to actually 0.4, 4 patches a day, but most patients don't want to use over 2 patches a day. And then parental estradiol, valerate or cypionate. We use the same dosing, whether it's valerate or cypionate. And again, you may be doing that weekly or maybe doing it every 2 weeks. If you're checking levels, you want to check it halfway in between doses. And then they may be likely on antiandrogens if they haven't had an orchiectomy. And so that would be spironolactone most of the time. And that's why you're checking a BMP. We do not have cyproterone here in the US. If they're on GnRH agonists, they're probably being followed by endocrine. Most of us are probably not doing that, but it is another, they could be on like Lupron or something. And then this is that information sheet or the informed consent, just so you have an idea of it. Okay, so on to masculinizing hormone therapy. And again, just leaning on the pathway for that. So again, you get this sort of step-by-step, it's just a nice reference of like, okay, did I check all these boxes? Not super in depth, but, and then if you need, oh, what was the diagnosis of gender dysphoria? You have it here. And then again, your supplies. So just note that folks on testosterone may be on intramuscular or subcutaneous. Usually estrogen will be intramuscular. And so the subcutaneous needles are different. And then again, referral to speech is here, other referrals, etc. So very similar, but the orders are specific to masculinizing therapy. And then we chose cypionate, for example, here, but it may be that if you're ordering this, a pharmacy could be out. So you may have to use an anthenate, and in which case you'll have to put that order in yourself. Gels, sometimes you may have to change. There's multiple different gels, and it's a little insurance dependent. Testosterone patches we use less, but that's there too. And then just to go the same order that I just did. So again, on crosscover, you're more in this monitoring. You might need to monitor. So we have for you the goal testosterone. If somebody's slightly over these goals, just to be very clear, we're using Endocrine Society goals. They're a little more conservative than some other goals. It's okay if somebody's slightly over these goals generally. You want to watch other things. For example, the thing you're really watching that is kind of rate limiting a little bit for us here in Colorado is the hematocrit. This is the one thing I'm going to go into a little bit because it comes up a lot. It'll come up in cross cover. Testosterone will cause some erythrocytosis, and that's worse here in Colorado because of our elevation. And so it's nice just to have, it's in that cross cover sheet. We even have it here. So usually we won't go up on the testosterone. I will say, hopefully whoever you're covering for checked a hematocrit prior to starting testosterone. And as long as their testosterone was normal prior to starting, as long as their hematocrit was normal prior to starting testosterone, you do not actually have to go into GAHT2, et cetera. It's really the first two. You're really looking at smoking and sleep apnea. And when you're over 55, you may end up reducing the testosterone dose. So say, for example, somebody's testosterone comes back at like 750, but their hematocrit is 48. So it's maybe a little elevated, but not terribly. Then I don't push, and their triglycerides are fine. I don't necessarily make them go down on their testosterone dose. So just so you know, these cutoffs are not super hard cutoffs. And like I say, at the end, I'll go through a little bit more about the erythrocytosis. The other things you're monitoring, so it's a CBC and testosterone like every 3 months until you get somebody at their goal levels, which is this 400, 700. The first 3 months, you're going to check lipids and LFTs just because they can go up. So it's nice to know if they are. Not all the guidelines suggest that, but that's our approach here. So, and just to go back through the changes caused by testosterone. So again, hopefully the dysphoria is improving. Unfortunately, you always have to use the diagnosis of gender dysphoria at this point in America for insurance to cover it. But, you can move from gender dysphoria to gender incongruence, which just means your gender identification doesn't match what you were assigned at birth. So a few differences between testosterone and estrogen is that facial hair, like that, changes to the hair are much more dramatic with testosterone. So most patients will get facial hair and changes to their body hair. Unfortunately, many will get alopecia. You will notice sometimes, and again, this can come up, that patients are on like a dutasteride or a finasteride and testosterone because of their male pattern baldness. Like that's a case where I'll let the testosterone ride a little higher because the finasteride will actually, those meds will, 5-alpha reductase inhibitors will kind of falsely elevate the testosterone a little bit because it blocks the action of testosterone, but it doesn't block actual testosterone production. So I'll let, as long as their hematocrits are okay and their lipids are okay, if their testosterone is 750, I'll let that be. I know this talk isn't like the tightest, most highly organized. I'm trying to hit the things that just tend to come up in cross cover a lot. Other major changes, increase in clitoral size. One thing that does come up, I would say, that patients like in terms of patients calling in, is some vaginal symptoms because it can cause vaginal atrophy. And that's a really sensitive topic in terms of how you're going to treat it. If a patient, it depends on a patient, you can use some topical estrogen, but that is likely to cause some dysphoria. So moisturizing therapies can help, that may be a reason that you refer to OB-GYN. If you refer to OB-GYN, refer to endocrine and say for OB-GYN, and then they'll go to the transgender, for transgender OB-GYN. Then they'll get in through the transgender clinic, and you'll get OB-GYNs that are competent in this care. Other changes, you do get the voice changes with testosterone, and those are permanent. Muscle mass changes you get those, but they're not permanent. Like if you stop the testosterone, those will reverse. And then some of the kind of cardiovascular potential changes are an increase in blood pressure. You do get this increase in hematocrit, as I said, and then pretty commonly we see a decrease in HDL and an increase in triglycerides. So again, it's nice to be, I think, aware of some of the changes people are having if they call in with questions. And the meds, it's all testosterone for the most part. Cypionate or ananthanate, we don't use undecanate here. It's a special process you need. And then, like I said, there's 2 concentrations of the gels just to be aware of. So you dose it a little differently depending. We don't use oral because it liver toxicity. The other meds you might find patients on, or that comes up, are for patients that have not had cessation of their menses, which is usually desired. And so for those patients, they're often on progesterone-based therapies, like sometimes an IUD, though that's not dependable in causing cessation of menses. And then more commonly, what our OBs do in the trans clinic, they'll start sort of higher dose norethindrone, agestin doses, like 5 milligrams, and then they'll bump it up to 10 milligrams. But they might be on lower doses, like more contraceptive doses of progesterones. That's the most common other med they're on. So some of the whys, we have a few more minutes. So I'm just gonna touch on the risks in terms of cardiovascular risks of estrogen and testosterone. So for estrogen, there really is a risk. And again, this could come up in cross cover, like it's a real risk of venous thromboembolic disease, strokes as well, cardiovascular disease, and then the other things I mentioned, like hypertriglyceridemia, actually gallstones, some weight gain. The rest of these are not clear and not likely. So in terms of heart disease, ischemic heart disease likely increased. Cerebrovascular disease, yes, it does increase your risk. Blood pressure, likely. Venous thromboembolism, yes. So just sort of when you're getting even, calls overnight, be aware. This is mortality data from this cohort, the Amsterdam cohort that was recently updated. So it's a very long term cohort. It's pretty much everyone in the country that's been on hormone therapy for this time. There's some real problems with this data. They didn't, especially early on, they didn't track risk factors for cardiovascular disease, but so they didn't account for it. But I'll look at, for these, I'll look at both trans women and trans men, so you can kind of see some of the differences. So for trans femme patients, when you compare to the general population of cis men and general population of cis women, so that's how these are set up, you can see that overall risk of mortality is higher for trans, for both, when compared to both populations. For trans men, it's a little higher, barely, it's higher for when compared to cis women, not when compared to cis men. And then when you look specifically at cardiovascular disease, for the overall cardiovascular disease, you see this increase it is at 1 when you compare to men and up, and then it's definitely increased when you look at compared to cis women. For trans masculine patients, it crosses, so there's no increase, no statistically significant increase. And then, but if you look at, so why are these increases? If you look at the real reason, I mean, not the real reason, but the more significant contributor to the increase in mortality, look down at non-natural causes, so suicide and other. That's where you get these larger, these much larger risks, and for both trans femme and trans masc, they're not as profound for trans masc patients, but still, and so that is why we are still providing gender-affirming hormone therapy. It's still considered, you know, we're saving lives, actually. You know, it's these rates, if people aren't getting care, you can see that it's like not suicide risk 6.8 over here, mortality ratio, whereas the myocardial risk, you know, okay, when you compare to cis women, it's 3.0, but overall cardiovascular disease, when you compare, this is a trans femme patient, when you compare to cis men, the overall risk is 1.4 cardiovascular. So for me, at least, that risk of suicide is much more profound. So, and then this is a US cohort done at Kaiser. It's much more similar to our patient population in a lot of ways. I'm not going to go into it, but this is trans feminine patients compared to reference cis men and reference cis women. And you again see this increased risk of venous thromboembolic disease. And it gets, it's higher for patients who just initiated in the last year, basically. And also, you don't see the increased risk of stroke actually compared to cis men, but you see it compared to cis women overall, and you see it in both in the first year. So skip this, and then this is, okay, sorry, I'm jumping around a tiny bit. I'm going to go to trans men, trans masculine patients in the strong cohort. So in this trans masculine cohort, as opposed to trans feminine patients, you don't see any statistically significant increased risk of venous thromboembolic disease, stroke, or myocardial infarction, either in that first year or overall. And then just to drill down a tiny bit more, there is this, sorry, I hope I'm not making you dizzy. Okay, back to this. This is one other, also pulled from the Amsterdam cohort. This is not mortality data. This is just a stroke, the existence of a stroke, a myocardial infarction, or a venous thromboembolic event. And I just want to point this out again. You see these increases for trans feminine patients, compared to both cis men and cis women. And in here, you see this increase in risk. So when you compare trans masculine patients to cis women, they did have an increased incidence of myocardial infarction. So they didn't have increase in mortality from myocardial infarction, but they did have an increased incidence. So this is why we say maybe. This is the kind of main reason. Maybe increased risk of. So the overarching for transgender males, trans masculine patients, we say, like, we give it in this particular study, they say no change, but we often say maybe there's an increased risk of ischemic heart disease because of that one study. No increased risk of cerebral vascular disease, no increased risk of venous thromboembolism, maybe increase of blood pressure, definitely decrease of HDL. And then just one last slide. on the hematocrit. So basically, in testosterone increases your hematocrit, and at most levels of elevation, in this study, it just increased it up to cis male range, normal cis male range. But in Colorado, we see higher increases, and so new erythrocytosis after starting testosterone. So hopefully you have a normal CBC, a normal hematocrit before. If you have a normal hematocrit before, if not, then you have to do like, your other workup. But if not, really, what you're looking at is sleep apnea and tobacco are your two biggest causes. You could, I don't explore other causes as well, depending on the patient. But I have diagnosed sleep apnea in a handful of young trans men that really don't fit any kind of picture of sleep apnea other than being on testosterone. So that's my biggest one. I try to encourage people to stop smoking. And then if you're at the point that you feel like you need to do something about it, I'm pretty lax. I don't usually change much if they're between 50 and 55. But you can change the route. If you change to transdermal, like a gel, usually it'll come down, because I think most likely because you're not getting the spike after an injection. And then also you can do more frequent dosing with the same total dose with that same idea in mind. You're not getting the big spikes. You could consider a dose change between 50 and 55. I don't usually until I'm over 55. And then you do want to do something if you're over 55. I'll say that when we had grand rounds with hematology and brought this up, they were like, oh, if it's new on testosterone, you don't have to do anything. So I will say this is a little more conservative than our hematologists. Some patients do choose phlebotomy or to donate blood because I have a patient that doesn't feel well if he's over 50 and he likes to keep his testosterone a little higher. That's pretty rare that we do that, but that is a possibility. So, there's several guidelines out there. Again, you can reference, the resources and the talk that I gave for more in-depth knowledge. You have the trans clinic at your disposal. You can always place an e-consult to endocrine and just say the transgender topic. So with that, I will stop sharing my screen and see if anyone has any questions. And if no one has any questions, I'll just, we can sign off because we are actually past. This was supposed to be 30 minutes, so we're at 35 minutes. So if there's no questions, we can wrap up. Alrighty.
Thank you.
You're welcome. And this
Yes, thank you.
This will be posted. Well, I'll have to listen to it. If it's not too embarrassing, this will be posted up on the website. So, all right. Take care, everyone.